Hello, everyone. My name is Omar Wilson. I am a member of Boston Scientific. Specifically, I'm the Diversity and Inclusion Program Manager for our endoscopy organization. I'm proud to be present today as a part of our Close the Gap initiative, which aims to educate and empower healthcare providers to reduce health inequities among underserved populations. I'm particularly excited and honored to introduce our esteemed panel today for the discussion on colorectal cancer and COVID-19. Aside from my family members that have been affected by both, I cannot ignore the fact that both colorectal cancer and COVID-19 has affected our Black community at disproportionate rates. Please help me to welcome our guests today. Our panelists, we have Dr. Renee Williams, who is an associate professor of medicine in the Division of Gastroenterology at NYU Grossman School of Medicine. Dr. Williams is the director of the Department of Internal Medicine's Organization for Nurturing Diversity. Her interests include health disparities in colorectal cancer screening and medical education. She is the recipient of the 2018 American College of Gastroenterology Minority Digestive Healthcare Award. Our other panelist, Dr. Alex Guillaume. Dr. Alex Guillaume is an assistant professor of medicine in the Division of Gastroenterology at Stony Brook University Hospital. She is the director of the Gastrointestinal Motility Center at Stony Brook, which specializes in the comprehensive evaluation of luminal motility disorders. Dr. Guillaume is the co-founder of the annual Thought Leaders in GI Motility Symposium held in New York, and a member of many GI organizations, including the American Neurogastroenterology and Motility Society. And last but not least, we have our moderator, Dr. Ugo Iroku, who is a board-certified gastroenterologist and is assistant professor of medicine in the Division of Gastroenterology at the Mount Sinai Hospital. Additionally, Dr. Iroku is an assistant clinical professor at the Icahn School of Medicine at Mount Sinai. He is medical director of New York Gastroenterology Associates, Brooklyn Heights office. Dr. Iroku has a long-standing passion for promoting public health literacy and empowering his patients to make their own informed medical decisions. As a public health expert, he has been featured on a number of national platforms, including TV news segments, radio interviews, podcasts, magazine features, and his own social media platforms. Dr. Iroku, I will now hand the floor over to you. And we thank you, as well as Dr. Williams and Dr. Guillaume, for the incredible and empowering work you are doing in our communities. Thank you, Doctor.
Thank you, Omar, for that very flattering introduction. And it's my pleasure to be here again with Dr. Renee Williams and Dr. Alexander Guillaume. And so we're here to talk about colorectal cancer in this COVID-19 days. And so we wanted to welcome you participants who signed into this very important conversation. We think it's important because we feel that stigma is a big reason why our community does very poorly sometimes with colorectal cancer disease. No one wants to talk about family history, obviously, oftentimes at the kitchen table, and definitely not when it comes to the colon. So we're going to jump right in, remove all stigmas, and talk about it. And so to start, I'm going to start by posing this question to you, Dr. Williams. This colorectal cancer we talk about, we can't talk about that without starting with the colon. What is the colon? And just explain what is it doing there, and why should we be talking about it at the kitchen table anyway?
So you don't need your colon. I'm joking. So essentially the colon is otherwise known as the large intestine. So in the mouth to the anus is one continuous tube, if you think of it that way. And you have like your esophagus, which is your swallowing tube, your stomach, which helps to digest, grind up your food. The small intestine actually helps to digest your food, and the colon eliminates waste. So the colon is a large intestine, and it's also like any other organ in the body, an area that cancer can develop. So we do colonoscopies because we want to prevent colon cancer, because as we all know, colon cancer is preventable, treatable, and beatable if you get it early and if you catch it early enough. And the colon, essentially, after you finish all your food, about maybe 1.5 liters of stuff goes into the colon, and it starts pulling water out, and it starts taking, and it does some absorption of nutrition, not much, but essentially speaking, then it actually, as it goes through, as the food goes through the food bowls or leftover food, then that, as it takes more water out, then you have the formation of stool, and that's what you pass when you have to get rid of excrement. But
Renee, they're asking you to use your outside voice, if you don't mind. Your volume is a little low. So just kind of scream at us, make sure we can hear you. They want to make sure they hear all the good information. It sounds like so far you said where the colon is, and you said the colon helps to convert the food from being mushy to actually being more formed and ready for the toilet bowl.
Let me do this. Let me put on, can you hear me better now, or?
Yeah, I can hear you better now.
Okay, sorry. I have headphones if I have headphones if that makes it easier, but I was basically saying that the colon is also known as the large intestine, and it helps to eliminate waste. And essentially speaking, after you've eaten your food, it starts pulling water out. It does absorb some nutrients, not much. Most of the nutrients are absorbed in the small intestine. And then essentially as it goes through the colon, more water is being pulled down and it becomes more solid, and that's where you have your stool. But like any other organ, the colon is also prone to colon cancer. And that's what we're here to try and prevent. It's a disease that really affects the Black community in a very large way.
That's right. So it sounds like we're saying, so someone says Dr. Renee needs to use their earbud. So while you set that up, I'll throw a question to you, Sandy, but I'll make a comment. So it sounds like we're saying that this colon cancer is not the prostate. Sometimes we hear a lot about prostate and prostate exams and prostate cancers. And I've heard a lot of my patients say that they think colon cancer is just something that affects only men. But we all have a colon, so that means that it affects women too. And that is the fact that the rates of having colon cancer in men and women are fairly similar. And the lifetime risk of anyone getting colon cancer is on the order of 5%. So that means if there are 20 people in your family, the odds are, just by odds alone, that 1 in 20 has a risk of having colon cancer. So it's a risk that everyone has. And that's why ultimately everyone needs to think about colon cancer screening. All right, so Dr. Guillaume, I've heard about this thing called the polyp. What's the connection between polyps and colon cancer? How are those two things related at all?
Hi, everyone. So a polyp is a growth that forms along the colon wall. And not all polyps are dangerous, but we can't tell by looking at it with the naked eye which polyps are dangerous. And so when we do colonoscopies, that's what we're looking for. Any abnormalities along the colon wall, these growths that are called polyps, so that we can remove them early on and look at them under the microscope to see if they're the type of polyps that potentially could harbor cancerous cells.
Okay.
So something I'd like to say, so when we take polyps out, the way I like to describe it is imagine a tree. A polyp could be like a tree's a growth, right? Imagine taking a lasso and putting that lasso around a tree and then cutting the tree off at the base. So that's how we remove polyps, essentially speaking.
Exactly.
Great. And so we love the fact that the questions are coming in already. We are completely here for you and your questions. So we're going to integrate your questions into our talk right now. So the first one that came in said, talked about at what age should one begin to have colonoscopies and how frequently. So before we answer that, let's just talk about screening colonoscopies. What does it mean when we say screening colonoscopy? What does that phrase mean exactly, Dr. Renee?
So when we screen for screening colonoscopies, what we want to do is we want to find a polyp before it becomes cancer. As Dr. Guillaume said, when we go in and we take these polyps out, there are certain polyps that have a chance of developing cancer. Like we see them, we know if we leave them there, they are 100% going to become cancer. But by taking those out, as I said, lassoing those out early on, it takes away that risk. So what they have found is with screening for colon cancer, and there are different ways to screen, over the last 25 years, the incidence, or I guess the amount of people that are diagnosed with cancer has gone down dramatically because we're now screening for the disease. So that's what a screening test is. Like people do mammograms because they want to check for early breast cancer or the signs. A screening colonoscopy or screening for colon cancer specifically is looking in the colon or doing a test to see if you have something that might be predisposing you to polyps or if you already have a polyp with the colonoscopy. So by taking those out, they never become cancer. And that's a pretty significant intervention that we came up with.
All right. So it sounds like we're saying that because of the risk that everyone has with colon cancers, even before you have any symptoms at all, you're going to do this screening colonoscopy to look for polyps. And the particular question was, at what age should we start doing colonoscopies and how frequently? Dr. Guillaume?
Great question. So this is something that I want everyone to take home, that the age for an average risk individual is 45. So we start screening colonoscopies as of this year at age 45. Now, if you have a family history, so if you have a first-degree relative, such as your mother, your father, your siblings with colon cancer, then you start your screening colonoscopies 10 years younger than the individual who was diagnosed with colon cancer. So for example, if they were diagnosed at the age of 50, then you would start your screening colonoscopies at age 40.
Okay, and so there's some technical questions that came in They were concerned about your analogy about the tree because they said trees have roots. And so if you're cutting out the base of the tree, isn't there a risk that the cancer cells will come back quickly, one question asked, or that it will remain in your colon? So explain how maybe the base, that base to the polyp, explain that to us.
So when I mention a polyp, the polyp is not cancer as of yet. It's precancerous or can become cancer, but it's not cancer per se. So we can tell by most of us just by looking at what we see, we can tell if this is a precancerous polyp or not precancerous polyp. If there's no cancer in the polyp, if it's what we call an adenoma, which is something that can become cancer, there is no base, essentially speaking, like there are no roots. Now, the truth of the matter is, if you do have cancer, yes, the cancer can spread similar to having roots inside the lining of your body. But most times, if we have a polyp that looks cancerous, we can tell. And that might change what we do. So certain polyps, if we take it out and we see cancer cells in the polyp, then we might recommend that you go to surgery specifically to cut that part of the colon out. But once something becomes cancer, and again, most times we can tell just by looking, not 100% of the time, but we know to, okay, we also check before to make sure that there's no cancer anywhere else, like in the chest or in the belly. So we normally do a workup to see if anything spread anywhere first, and then that gives us an idea as to what stage you are. And if you're a stage 1, then we can just cut that out right away. So I think if the polyp is not cancerous or precancerous, then there are no roots. I should have put that in there. My apologies.
Yeah, she's using the tree as an analogy, but in actual fact, the polyp is all at the top and the bottom area is completely safe and normal. And the pathologist who we send the slides to looks to make sure that there's nothing left in your body. All right, so there's a great question as to what are some proactive health tips we can use to take care of our colon on a daily basis. So I think of this as modifiable risk factors for colon cancer. What are some things that we can do to make sure our colon is healthy? Dr. Guillaume, you want to answer some of this?
Yes, absolutely. So great question. There are definitely modifiable risk factors to mitigate your chances of developing colon cancer. And it starts by just taking a healthy approach to yourself and your body and your mind. So things such as diet, things that you can do in your diet, such as minimizing red meats, minimizing processed meats, cold cuts, things of that sort can strongly decrease your chances of colon cancer. Reducing the amount of alcohol that you use, not engaging in smoking, anything, cigars, cigarettes, all of that can mitigate your risk. In addition, trying to maintain a very active lifestyle, so active exercise can strongly also decrease your chances of colorectal cancer. Keeping within a healthy weight range for your body type, your age, your height can also strongly reduce your risk of colon cancer.
That's an excellent answer. Dr. Renee Williams, you want to talk about, we talked about screening using a colonoscopy, but our conversation wouldn't be complete without talking about other methods of screening for colonoscopies. You want to talk about some other methods that exist?
I am. Someone actually mentioned in the chat what a colonoscopy screening procedure is. So I'll start with that and I'll discuss. So when we talk about screening for colon cancer, there are different ways. So we are gastroenterologists, so we're going to tell you to have a colonoscopy. I'll say that. And what the colonoscopy is, it's an invasive procedure. It's very safe, and any procedure has risks. And what we do is we put you to sleep and we take a tube with a camera and a light, a very long tube, we go inside your bottom and we look around your colon, and your colon is almost like an upside down U. So we go all the way to the end of the large intestine, almost the beginning of the small large intestine or the end of your small intestine. We come back very carefully and start looking around to make sure that we catch everything and see everything. And if we see anything abnormal or pulse, we take it out right away. So the colonoscopy itself is just a tube going inside and looking around your large intestine. Now that's one way to screen for colon cancer, but not everyone wants to have an invasive procedure. So there are other things that you can do. Something that is also equivalent you can do is like a stool-based testing. So we have tests that specifically look for blood in the stool. And there are two types of tests. There's one called a FIT test, and there's also a stool DNA test. And both of these tests looks for blood in the stool. And if those are positive, then essentially speaking, what we do is you have to go and get a colonoscopy. So think of it as like a one-step versus a two-step way. One step is a colonoscopy. You go and you see it, you take things out, or it's a clean colon, you're done. The two-step is like you could do a stool-based test, and if that's negative, then you have to do it depending on the stool test you're doing. If it's a FIT test, it's every year. If it's a FIT DNA test, it's every 3 years. And if those are positive, then you have to get a colonoscopy. And someone also mentioned a colonography. So essentially the colonography specifically is what we call a CT colonography. It's very similar. It's like a CAT scan. If any of you've ever had a CAT scan, you still have to drink the prep. The prep is the worst part of getting a procedure done. It's a cleanser. It gives you diarrhea for like a day. It's not pleasant. I'll openly say that. And then what you do is you have to drink that before a colonoscopy or a colonography. And then when you come in for the colonography or CAT scan colonography or virtual colonoscopy, what they do is they insert a small tube into your rectum and they blow you up with air. And then they get like pictures of the colon. They do like 2-dimensional pictures and 3-dimensional pictures. And essentially speaking, if they see anything abnormal, then they'll say, hey, guy, you have a polyp, you need to go get a colonoscopy. So understand that the non-invasive testing or less invasive testing, it's a good way to go if you don't want something invasive. But if they are positive, you have to get that colonoscopy done afterwards. And go ahead.
Just to, very quickly on the point as to whether it's more accurate. This has been studied, of course. The colonoscopy is the most sensitive. So in other words, if there is anything in your colon, the colonoscopy is most likely to show it because that's us looking with a video inside your colon. So nothing's going to be able to replicate that. After that, the CAT scan colonography comes in. And then after that, stool-based testings come in. So colonoscopy is the most sensitive, most able to discern small polyps. Sorry, Renee, you were about to say something else?
So a difference with the virtual colonoscopy, and again, it's a good test if you want it, it might miss things. So for example, some polyps are like trees and some polyps are like domes or hills. And some polyps are kind of flat, meaning it's almost like you have a very flat, imagine like instead of a flat surface, you just have something that's kind of like a little bit up. We are in there physically, we can see that with a colonoscopy, but if you have a CT scan, they might not necessarily see those kind of polyps. So they're different types. They're flat polyps, they're kind of like halfway flat polyps, they're like tree-like polyps. So they're different types, and depending on what you're doing, it might pick up different things in different ways.
All right, and so you mentioned fit DNA, and someone saying which one is ColaGuard and how frequently should you do ColaGuard? Dr. Guillaume or Renee, you can take that.
So the ColaGuard is the fit DNA. So it's a stool DNA test where we're looking for DNA markers in the stool that can suggest potential cancer. It's combined with the FIT test because the FIT, which stands for fecal immunochemical testing, because it actually tests for human blood. So we're looking with the ColaGuard for a combination of both human blood in the stool and also certain DNA markers or certain DNA genetic markers that predispose to cancer. So that combination together is the stool DNA test, and the ColaGuard is what is a fit DNA test. That's
excellent. I love the engagement we're having a lot of great questions here. Another one came in saying a little vignette of a story. There's no family history of colon cancer per se, but if someone had a colonoscopy in the early 30s and found polyps, how frequently should you repeat a colonoscopy? So in other words, address the family history of colon polyps, even if it's not colon cancer, Dr. Williams. So if someone in their 30s has colon polyps, what does that mean for that person and for everyone else in their family?
So it depends on the type of polyp that you have. So if your polyp is what's known as, and we should actually say, since this is Black Health Matters, that we, within the Black community, we see colon cancer at a much higher rate. As much as cancer rates have gone down and deaths have gone down in the last however many years, when it comes to the Black community, we have a higher rate of cancer and we have a higher death rate from cancer. So that's why it's a really important thing for us to really know about as a community. So it depends on the type of polyp you have. So there are certain polyps that have no risk of becoming cancer. So if you're in your 30s and that's what you had, then you should start screening at 45. But if you have something called an adenoma, and it's really important to speak with the doctor who did it or the pathologist. So if you have an adenoma, then that changes your time. And if you're in your 30s, that's a little early for you. So if you have an adenoma, then depending on how many polyps you have and the size, you may have to repeat a procedure in 3 years or 5 years or 10 years, depending again on a lot of different factors. So you need to know what type of polyp you had, because adenomas or the polyps that have those aspects to it are the ones that can develop into cancer over time. And if we see a certain amount or a certain size, for example, if your polyp is over 1 centimeter, then you come back in 3 years. So that determines in terms of the frequency for you coming back. So it's something that's really important to know. So if you're in your 30s and you have an adenoma, then you should come back at an earlier age in 3 years or 5 years, depending. And then you should probably speak to your family members about getting colonoscopies early too.
And again, we just want to remind you that this is for educational purposes only. You should definitely connect with your primary care doctor and your gastroenterologist for very specific recommendations, because they'll be able to see all the details that you just can't communicate in a few sentences. We'll try to give you a general understanding of which direction the education says, though. So on that front, there's another similar question that says, someone is 42 and they had a family history of people having polyps in their 50s, and a grandmother who had colon cancer. And so in general, with a grandmother with colon cancer and then people with polyps in their 50s, when should that person get their first screening, Dr. Guillaume?
So I'm really happy to hear this. I'm happy that at 42 you're paying attention to your family history, because many of us don't know our family history. And so this is the time. The fact that it sounds like there are multiple family members, second degree family members with either colon cancer or the possible high-risk colon polyps, then in your 40s is when you should start your screening colonoscopy. And I think your question was asking, how do you navigate the process? It seems like this individual had some difficulty getting a timely colonoscopy. So if that's the concern, that you're not getting scheduled soon enough, one thing is to be persistent. Is to definitely be emboldened and speak to your doctor and say, hey, it sounds like I'm being scheduled 6 months from now. I really would like to see if I can get this done sooner. What are some of the things that I can do to get this done sooner? And if that individual can't schedule you, and you have a relationship, you can maybe talk to them about some of the other tests that we've suggested that you can do in the interim that can give the doctor a clue as to what your chances are. So something can be done. As Dr. Williams mentioned, the stool test, the FIT test, or the FIT DNA test can be done at home. There may be some insurance issues, so always talk to your provider about particulars, but there are things that can be done while you are waiting for your test. If you're looking for a provider that looks like you or looks like any one of us here. We're all members of an association called the Association of Black Gastroenterologists and Hepatologists. And soon we'll be able to provide the public with a list of gastroenterologists nationwide that you can actually look up and see if you can connect with for an appointment.
Okay. All right. So another question came in. What are the differences between colorectal cancer, colon cancer, and rectal cancer? Dr. Williams, you want to cover that?
So essentially, they're all the same thing. The term colorectal cancer kind of is an umbrella term. So the colon cancer specifically is cancer restricted to the colon. So your colon, as I mentioned, is a large intestine, but it's actually really made up of two aspects. There's a colon and there's a rectum. The rectum you're very familiar with, because every time you need to poop, you feel that pressure. That's your rectum acting and saying, hey, pay some attention to me. So essentially speaking, if you have rectal cancer, that's restricted to the end of the large intestine, which is the rectum. Colon cancer is cancer that's within the colon itself. But when we say colorectal cancer, we just refer to everything across the board. In general, when we say we tend to use colorectal cancer as a more inclusive term, but pretty much it refers to the same process.
All right, so a couple of questions are coming in as to how you can actually prevent colorectal cancer. One person said, can colorectal cancer be prevented? The other said, is colorectal cancer hereditary or is it more lifestyle based? Currently, you would imagine, I think most people think when they think of cancer, they think it's just something that happens in families, and they say, well, I don't have a family history of colon cancer, so it's not going to happen to me. It turns out that it's the odd cancer that is related to family disease. It's actually a fraction. Most happen in family in situations where there is no other known colorectal cancer. So it's not primarily hereditary. And in terms of what can you do to prevent your risk, it's all the things Dr. Guillaume said. It's eating the high fiber diet, exercising, making sure you're getting your rest, stress management, cutting down on red meat, not smoking, not overdoing alcohol. Those are the things you'll hear all your doctors tell you over the years. Those are the modifiable risk factors, the things that you can change to decrease your risk of colon cancer. And yes, it is preventable by doing those things. And then the non-modifiable risk factors like, your age, you're more likely to get colorectal cancer the older you are, or your race, Black people are more likely to have colorectal cancer by 20% over white people, and we're 40% more likely to die from it. For those non-modifiable risk factors, we manage that by doing screening. And so if you get your screening colonoscopy and you live a healthy lifestyle, that's your way of preventing colon cancer.
A very small percentage of people have it is genetic. Again, as Dr. Uroku said, most of it is just sporadic, meaning it just randomly happens, but a very small percentage of people do have like genetic or hereditary predisposures. But what happens in that case is you'll see a cluster of colon cancers in different family members who might be young. And in our field, there are specific rules that say if you notice these particular aspects in a person's history, then they need genetic testing. So depending on your history and a lot of other factors, your doctor may refer you for genetic testing, because if you do have a one of the hereditary or genetic predisposition, it changes things a lot. But that's a very small percentage of people.
Yeah, so for instance, like 150,000 people will get colorectal cancer in a given year, and of that, about 3% of them will be one of the Lynch syndromes. So one of the cluster of diseases that can cause colorectal cancer. So that's about like 4,000 or so a year. So in relative terms, it's more likely just to be not related to a family history. But if you do have a lot of cancers occurring in your family, many people with polyps, many polyps in a given colonoscopy setting, these are the questions to start asking your question to see if you need to be tested or your family should be tested for some of these other syndromes. All right, great question. What are some signs and symptoms of colorectal cancer? Dr. Guillaume, you want to take that?
Yes, I'm glad we didn't miss that one. So, we were talking about screening colonoscopies, which tend to happen when there is a lack of, there's no sign or symptom of colon cancer. And colon cancer, by the time that it is manifesting with a sign or symptom, the chances are that we're finding, as Dr. Williams said, a more advanced type of polyp. So things that you should be looking for are a change in your bowel habit. So if all of a sudden you were someone who would regularly have bowel movements, and then you tend to notice, you're seeing a decline in the frequency of your bowel movement, or you're noticing any change in the shape, the consistency of your stool, that is something you should bring to your doctor's attention. Definitely if you're noticing any blood in the stool, blood in the toilet, or blood even when you wipe, you should bring that to your doctor's attention. Any abdominal discomfort that persists, in spite of sort of traditional measures that you may take at home, any unintentional weight loss, okay, any type of nausea, any weird feeling that you're not sure what is going on, you should bring to the attention of a medical provider so that can be addressed very soon.
Something I like to tell patients, specifically speaking, is your body. Like you've lived with yourself since you were born, since you came out of the womb. So if you feel something is off, then just make sure that you advocate for yourself. Because I think a lot of times as people of color, we tend not to really advocate for ourselves, but it's your body. And if you feel that if you're seeing blood in the stool, as Dr. Guillaume said, if something's just not right or something's off, then follow your instinct to make sure that it's investigated appropriately.
You don't have to be both. You don't have to be both the patient and the doctor. So odds are it's nothing dangerous, but bring it to the doctor. Let's help you think through it, because then we'll tell you some short-term measures that should get the symptoms under control. And if that doesn't work, then we can consider some more advanced testing. It's very important with colon cancer because colon cancer is very preventable, but it's also very treatable. And so when we find colon cancer at early stages, you have a 95% likelihood of being cured from it in a 5-year range. And so if you come with your symptoms, it doesn't mean it's a death sentence. We see many people get colorectal cancer and beat it completely. We probably have about 60 seconds left. And so we're going to—
I'm going to say, if you have rectal bleeding, don't let someone tell you it's just hemorrhoids, especially if you're like 45,
Absolutely.
46. If you're having rectal bleeding, get a colonoscopy. It could just be hemorrhoids. Most likely it is just hemorrhoids. But honestly speaking, in our community, have them investigated.
All right, so thank you guys. There's so many amazing questions here. But what I can tell you is that we are here, again, the three of us happen to be in an organization called Association of Black Gastroenterologists and Hepatologists. We exist to help with these kind of conversations. But I'm gonna switch to asking for big takeaways. Dr. Renee Williams, what would you tell the person out there who's hearing all this and they're not really sure whether or not they should be concerned? Is this something they should be scared about? Is this something that is a big fear item? How can they kind of process the weight of this whole colorectal cancer topic that we're talking about?
So something I would say is talk to your doctor about screening. So one study has shown that, in specifically looking at Black patients, that a lot of times where providers do not recommend screening for colon cancer, and that's a big barrier. We talk about all these different disparities in health and healthcare, and we see these disparate outcomes. And studies have shown that providers are not recommending screening to their Black patients. And I think it's important that if your primary care provider does not bring it up, then you bring it up. Say, hey, I want to talk to you about colon cancer screening and what are my options? There is a variety of options. You can do colonoscopy, you can do the stool-based testing, you could do CT colonography, but initiate that conversation if your primary care doctor isn't starting it for you. I'm all about advocating for yourself.
That's right.
Absolutely.
Dr. Guillaume, do you have any final words for the audience?
Just a question that comes from the chat, that there are other Black gastroenterologists and hepatologists that look like us out there. I know there was someone looking for a doctor in Massachusetts. There's a way that you can connect with Black Health Matter. We will help you connect with a gastroenterologist, male or female, that I think you will be comfortable with. So as you know, my co-doctors here are saying, no, if you know your body, you're concerned about something, bring it to the attention of a physician. If you're over the age of 40, 45, ask for a colonoscopy, whether you think you need it or not. Get it done. Colon cancer is preventable. We can beat it and we can treat it.
Excellent. Okay. And to wrap up, can you tell us how we can get in touch with you, either on social media or in person, if anyone's interested in following up with you? Dr. Williams, quickly.
I'm on social media. I'm on Twitter, I guess. It's the easiest way. Just if you type my name in Renee Williams, NYU, I'll pop up.
Okay, so you're a physician at NYU, and you, Dr. Guillaume?
Same here. I'm on Twitter, Alexandra Guillaume. I'm also a gastroenterologist out on Long Island in New York at Stony Brook. I can easily be reached and can help you if you're looking for a doctor in another state.
Okay, and I am a gastroenterologist in New York City. My name is very unique, but my Twitter handle is @RealDrUgo, all spelled out. RealDrUgo, all spelled out. You can find us there. And so thank you. Please reach out to us if we can help in any way. We can connect you to someone who can. And it's been a pleasure being on this panel with these amazingly brilliant physicians. And it was a pleasure getting to talk to you all as well. Thanks for joining us.
Thank you.
Take care, everyone.
Bye. Sorry I couldn't answer all the questions. A lot of good ones. Thank you.
Great questions, yeah.
Bye.